Good afternoon, everyone. We are going to just take 1 minute to let the room fill up before we go ahead and get started with our presentation. Thank you all for joining us today. Just give it one more second. Okay, thank you for joining us once again for our weekly Wednesday webinar series. Today's webinar is on rare diseases in the PLAIN community. My name is Alsa Murtha, and I'm the Manager of Strategic Communications here at the National Hemophilia Foundation. This webinar has been pre-recorded. We have questions that will be presented to our speakers after the presentation, if time allows. This webinar will be available to the community beginning on Friday, February 25th. I am joined today by Dr. Zineb Ammous and Dr. Magdalena Lewandowska. Thank you both for taking the time to join us today. I will now turn it over to you to get us started.
Hello, and thank you for having me today. My name is Dr. Ammous. I'm a clinical geneticist, and I'm the medical director of the Community Health Clinic, which is located in Topeka, Indiana. And today I'm going to be talking to you about the PLAIN community and some of the rare diseases that we see. So first, who are the PLAIN people and where are they located? The PLAIN people are descendants of Swiss Anabaptists who escaped religious persecution in Europe about 300 years ago and settled in North America. We call them PLAIN because of the way they dress. The majority are Amish, but Mennonites and Heterites are also part of this group. Both population bottleneck and the founder effect contribute to the high prevalence of rare genetic disorders seen in these communities. And as you can see here, the PLAIN communities are located in over 30 states and also in Canada, but about 2/3 are located in Pennsylvania, Ohio, and Indiana, with the largest community being around Holmes County in Ohio. The PLAIN people choose to separate themselves from the rest of the world and avoid using technology, including the use of phones. They do not participate in social security programs and do not have health insurance. They also have 8th grade education. All these factors are barriers to care, especially when we're talking about rare disorders. One of the very first physician scientists who became interested in this community is Dr. Victor McCusick, who noticed the high prevalence of dwarfism in the Pennsylvania Amish. His work with the community laid the foundation for what is now known as the field of medical genetics. However, what Dr. McCusick started in the 1960s was considered genetic tourism, where students, physicians, and scientists benefited from working with the PLAIN community. They studied and published about rare genetic disorders, but did not provide any care or follow-up for those who are affected by these rare disorders. It wasn't until 1989 when Dr. Holmes Morton founded the first clinic in Eastern Pennsylvania that was dedicated to providing local and affordable care for Amish and Mennonite individuals affected by rare metabolic disorders. Inspired by his work, you can see that now there are multiple other clinics that have since opened in the heart of other PLAIN communities, including the Community Health Clinic, which is located in Indiana. The Community Health Clinic was founded in 2008 through a collaboration between the Indiana Hemophilia and Thrombosis Center and the Amish community, and it opened its doors in 2013. This is a picture of the clinic. For the rest of this talk, I'm going to refer to the Community Health Clinic as the CHC. The CHC provides local, affordable, well-coordinated, and culturally sensitive genetics care to those who are most vulnerable in the PLAIN community of Northern Indiana and surrounding states. The CHC acts as a medical home for these patients and their families. Some of the services that the clinic provides are genetics care, genetics counseling, nutrition services, newborn screening follow-up, discounted lab services, case management, specialty and outreach clinics, home visits, palliative care, education, and participation in research. Since its opening in July 2013, the CHC has evaluated about 4,000 patients with over 150 different genetic disorders. About 53% of these patients are pediatric, and 90% of these patients are from the plain community. And they come to us from 15 different states, but mostly the Midwest region. And what I'm showing you here is the location of the clinic. You can see it represented by the yellow star. And with the blue stars there, we have the different outreach locations where the clinic staff travel to see those who cannot come to us to the location in Topeka. And so we go to different locations in Indiana. And in addition to that, we go to 2 locations in Michigan and also 1 location in Kentucky. As I mentioned earlier, one of our services is providing newborn screening follow-up. This was actually the very first service that we started with in summer 2013. The CHC provides care for those with inborn errors of metabolism, spinal muscular atrophy, severe combined immunodeficiency, and X-linked adrenoleukodystrophy for 19 counties in Indiana. And we have patients who come to us with some of the most complex inborn errors of metabolism, like maple syrup urine disease and organic acidemias. And instead of having to go all the way to larger cities, these patients are able to do all their follow-up with us in Topeka. And if they need any hospitalizations, they are admitted to local and regional hospitals where they can get all their metabolic needs. One well-known disorder detected by newborn screening is PKU. One of the CHC goals after its opening in 2013 was to improve care for those who are affected by PKU. PKU is the most common inborn error of metabolism seen in the plain community in Indiana. And for the past 8 years, we've been able to learn about the founder variants causing PKU in our community. And you can see those 3 founder variants underlined in this table. We can now easily predict the severity of the disease and the response to treatment based on the genotype. Whenever a new family comes to us, we can get this testing done pretty quickly, and we can predict whether their child is going to respond to certain treatments or not, and we're able to provide them with a personalized approach. In addition to the inborn errors of metabolism, we see now patients with some other disorders coming to us through the newborn screening program. One of these disorders is spinal muscular atrophy. This is a neuromuscular disorder that used to be considered a terminal or lethal disease, especially in the Amish community. None of the affected patients lived beyond 2 years of life. However, this is now a treatable disorder. There are 3 FDA-approved treatments, including gene replacement therapy, and our families are able to access all the new treatments through a special program at no cost to them. In addition to metabolic disorders that we see through the newborn screening program, we see other ultra-rare disorders that currently do not have treatments. And in this picture here, you see one of our Amish patients with an ultra-rare condition known as Niemann-Pick type C2. And we are able to follow these patients in our clinic, including those who are on investigational new drugs. If left untreated, a lot of these metabolic disorders cause cerebral palsy. Whenever we have a new family coming to us looking for answers and they have a diagnosis of cerebral palsy, we recommend a genetic workup. There are many reasons for this recommendation. The first is to provide the families with answers, knowing their recurrence risk for the disorder, but also because the treatments are very different. Some of these disorders have treatments, others do not. And these two pictures represent two of our patients who have two metabolic disorders that are currently untreatable. Both of these are considered metabolic disorders. One is a GM3 synthase deficiency and the other is non-ketotic hyperglycemia. These are both very rare disorders in the general population, but they are actually quite common in the Amish population. There are over 100 cases of GM3 synthase deficiency in the Amish. This is a very devastating disorder. It is considered a neurodegenerative disorder with very poor neurological outcomes. And what one of our goals at the clinic, and actually our sister clinics who work with the Plain community, has been to learn more about GM3 synthase deficiency and potentially find a treatment that we can provide early in life. The second condition that I mentioned earlier that is quite rare in the general population, yet very common in the Amish community, is non-ketotic hyperglycemia, also known as NKH. This is also a very disabling neurological condition. And a 10-mile area of northern Indiana has the world's largest concentration of patients with NKH. And so at this point, we are working with several scientists from the area as well as national experts to learn more about NKH, its natural history, and also looking for potential therapies, specifically gene therapy. Because these patients have such complex disorders, it is very important for us to not only provide them with genetics care, but also have other subspecialties available to them. And as I mentioned earlier, it is very difficult for individuals from the Plain community to travel to large cities. These individuals do not drive, so they have to hire a driver to go to any appointment. And for that reason, what we're trying to do at the clinic is to bring in all the specialists to our clinic so they don't have to travel far. They can come to us by horse and buggy, or they can hire a driver, but just drive a very short distance. And at this point, we have some specialties that come to our clinic, and our hope is to have more with time. Not only we are able to provide these patients and families with affordable care, but we are the experts in their genetics, and we have the time to spend with them. We have the time to study these disorders that are quite prevalent in the community and find new treatments, and there is no price tag on that. So the clinic has made a huge difference since it's been available to these families. In the last year or so, one of the new things we've been focusing on is establishing a research department at the CHC. It is very important to incorporate research into our daily patient care. And one of the first things we started with is focusing on genetic discovery and knowing what is out there in our community and what the needs are. And as I mentioned earlier, it's very important to know the etiology of these symptoms or of the phenotype, because the treatment could be very, very different from one patient to the other. And what you see here is a graph that represents the rate at which the discovery of pathogenic variants in the Plain population has increased since introducing advanced molecular genetic technologies, and especially after the introduction of whole exome and whole genome sequencing in the last 5 years. Collectively, we went from about 10 pathogenic founder variants when Dr. Holmes Morton started his work in Pennsylvania to over 350 variants in 2019. And over time, we have been able to compile a long list of the different founder variants seen in the plain community. And this has led to the development of a panel that includes about 1,400 different variants. This panel is called the Plain Insight Panel and is now offered to couples from the plain community who would like to learn about their carrier status for these different rare disorders. With carrier screening, we would be able to detect couples who are at risk for having children with these rare and ultra rare genetic disorders, and that would allow us to have a pre-symptomatic or at least a very early diagnosis, especially at a time now where we have all these new therapies. So the ultimate goal for us is to have the right treatment for the right child at the right time. That's all I have.
That was great. Thank you so much for sharing. All right. We are ready for you, Dr. Lewandowska, whenever you're ready.
Hello, good afternoon. Thank you so much for having us today. My name is Magdalena Lewandowska. I'm an adult hematologist at the Indiana Hemophilia and Thrombosis Center located in Indianapolis, Indiana. And today, my portion of the discussion will be to review the bleeding disorders that we see and treat in the plain community. So as Dr. Ammous described, there are approximately 361,000 Amish adults and children that live in North America, the bulk of which are in the 3 states in the Midwest. And what part of the discussion today is really our intervention in the population that we treat here in Indiana, of which there are 60,960 members of the plain community. So there are several bleeding disorders that are that affect our Amish patients, and essentially the restriction in the gene pool is the primary cause. Their factor VIII deficiency is fairly as expected, affecting approximately 1 in 3,800 males with severe factor VIII deficiency in the plain community. With factor IX deficiency, it's very interesting because, as it would be expected, to affect approximately 1 in 20,000, which is the average prevalence worldwide, here in Indiana, within the plain community, we have a prevalence of approximately 1 in 435 males. We have 70 males that are affected with moderate factor IX deficiency, which is quite interesting. And in honor of Rare Bleeding Disorders Month, we'll spend a little bit more time discussing some of the rarer disorders that we do treat, that we see within the plain community, including dual diagnosis patients who are affected with both factor IX deficiency and von Willebrand disease type 2M, of which we have 2 males and 1 female at the moment. We have 102 individuals with von Willebrand disease type 2M who are currently under our care at IHTC within the plain community. We have 10 individuals who are affected with a very rare bleeding disorder called PAI-1 deficiency. Those 10 individuals that we'll discuss are in the homozygous state. We have many more heterozygotes who do not have very many symptoms. And in general, we expect that prevalence to be somewhere closer to 1 in a million. And here, it's about 1 in 6,000 Amish patients that are affected within our plain community here in Indiana. And then we'll talk a little bit about HHT. The patients, we have approximately 8 individuals all within the same family with hereditary hemorrhagic telangiectasia that we treat here in our clinic. So I'd love to spend just a little bit of time discussing one of the rarer subtypes of von Willebrand disease type 2M. So von Willebrand factor binds to several receptors. The platelet glycoprotein 1b receptor through the A1 domain, as well as collagen 4 and 6 through the A1 domain. And then von Willebrand factor binds to collagen 1 and 3 through the A3 domain, as depicted in the image right here. This is a qualitative variant that's characterized by defective platelet adhesion and or collagen binding. What's tricky about von Willebrand disease type 2M is it sometimes is difficult to discern from other subtypes of von Willebrand disease. It can be disambiguated from type 1 because of the abnormal ratio between the von Willebrand factor activity to antigen, which is generally less than 0.6. The multimers, however, are normal. And the collagen binding assay sometimes provides us with the only clue that this truly is not just a typical type 1 von Willebrand patient. We do often pursue genotyping whenever possible, whenever we do suspect that this is the subtype of von Willebrand disease. And it is really important to make sure that we make the appropriate diagnosis in order to ensure that the patients receive appropriate treatment, because the majority of these patients will not respond to desmopressin or DDAVP. So the clinical features of von Willebrand disease type 2M can be variable, and it's a mucocutaneous bleeding phenotype, as we would expect with von Willebrand disease. And we often see epistaxis, easy bruising, heavy menstrual bleeding. Postpartum bleeding is very common, as well as post-surgical bleeding. It is caused by a single mutation, and we try to genotype the individuals whenever possible. The median von Willebrand factor activity is approximately 13% in our patients, and the antigen is approximately, the median would be approximately 23%, with a ratio of just under 0.6. So one of the more common manifestations of VWD type 2M, and probably the most common complaint and patient symptom that we manage, is abnormal uterine bleeding. And there are several challenges in treating the plain community, which we'll discuss, that make management a little bit different. So within the general population, about 17% of women with heavy menstrual bleeding have a hemostatic abnormality. And the prevalence of von Willebrand disease in these women is approximately 13%. There is a Canadian cohort that was evaluated with von Willebrand disease type 2M, and approximately 70% of these women reported heavy menstrual bleeding. In our patients, however, there was initially a lot of underreporting with heavy menstrual bleeding, even though it does exist, and we know it exists based on more specific, culturally sensitive questions being asked in the appropriate clinical setting, and based on the fact that these women were becoming anemic on home hematocrit and hemoglobin checks. Essentially, it is a stoic population of patients. There's always the concept of relativism, right? Meaning everybody in our family has very, very heavy periods. My mother, my sister, my cousin all have a hemoglobin of 8. And they've all had heavy menstrual bleeding for as long as they can remember. And so hence, this is just, a part of life. The bleeding score is also very tricky because some of these women may not have sought medical intervention or consultation with a subspecialist for management, for example, of nosebleeds or heavy menses. Generally speaking, we treat heavy menstrual bleeding in the plain community with tranexamic acid or aminocaproic acid. It tends to be better accepted compared to hormonal therapies, and women seem to tolerate tranexamic acid a little bit better when it comes to gastrointestinal side effects compared to aminocaproic acid. We do have also a homegrown labor and delivery plan for women with von Willebrand disease type 2M. And over the years, Dr. Shapiro has developed a tiered risk stratification for factor replacement, where women are risk stratified into one of three tiers. And really, this is based on personal or immediate family history of bleeding at childbirth. So the first tier, tier 1, is the lowest risk, meaning women who have had deliveries with no history of abnormal bleeding or excessive bleeding, no first-degree relatives with postpartum bleeding that had required treatment, or if it's the first delivery, but really no history of abnormal uterine bleeding or many bleeding symptoms with a low IHTC VAT score. With the second tier, we do recommend replacement with plasma-derived von Willebrand factor product prior to delivery. And essentially, this is for any women who have had a history of abnormal bleeding that has led to anemia, any prior hospitalization that was due to an excessive bleeding for any other intervention, or a prior history of bleeding with another delivery for which they had not received treatment product. And also, if there's a first-degree relative with a significant history of postpartum bleeding, we also automatically move these women to the second tier of treatment. The third tier is any C-section, any anatomic reason, for example, like a large tear at birth that would require additional factor replacement, any excessive bleeding requiring intervention despite being in a prior tier, for example, in tier 2 in the past. We do have and are lucky enough to have outreach nurses that do provide peripartum monitoring. They perform home visits on postpartum's day 1, 3, 5, and 10. We do have a portable hematocrit machine that we monitor the patients to ensure there isn't excessive blood loss around those periods of time. And so essentially, this has become a well-accepted practice amongst our patients within the plain community, and our rates of bleeding seem to be very low. So to summarize, von Willebrand disease type 2M is a mild to moderate bleeding disorder, and there's a variable bleeding phenotype. It can be difficult to diagnose due to variable laboratory testing. It may or may not respond to dd-AVP, and the majority of patients require von Willebrand factor concentrate. And so really, we want to remember to perform collagen binding assays and genotype whenever feasible. And really understanding the clinical phenotype can help guide clinical treatment. So this is a patient case which I thought would be interesting to discuss. It's a patient with a combined diagnosis of von Willebrand disease type 2M and moderate factor IX deficiency, where the mom of this patient is a factor IX deficiency carrier, and the father has von Willebrand disease type 2M, and they were patients of our clinic prior to their marriage, and now there are 3 affected offspring who have both bleeding disorders. So this is a patient for whom the bleeding symptoms included epistaxis, there were some spontaneous hematomas, easy bruising, and several episodes of hemarthrosis. And this is a patient who also has a very active lifestyle and is very heavily involved in farm work, wherein the decision was made to start on prophylactic therapy for his factor IX deficiency. And initially, he was treated with recombinant factor IX, which he tolerated very well for several years. He, at the age of 12, underwent a tonsillectomy and adenoidectomy with a perisurgical plan that included additional recombinant factor IX replacement, as well as plasma-derived von Willebrand factor replacement, and postoperative tranexamic acid for the antifibrinolytic component. So he was adherent to the first part of the plan, but forgot or was unable to take the tranexamic acid postoperatively, and developed resultant bleeding. And upon admission and additional product administration, he developed angioedema in response to recombinant factor IX, and then to recombinant factor IX FC. And he did not have an inhibitor on serial testing. He was eventually switched to a plasma-derived product for secondary prophylaxis and has been doing very well since that time. And in addition to his prophylaxis, he is treated with additional hemostatic coverage as needed with plasma-derived von Willebrand factor for treatment of his von Willebrand disease type 2M. So moving on to another rare bleeding disorder, which we treat in the plain community, PAI-1 deficiency. So Plasminogen Activator inhibitor type 1. We'll briefly discuss the role in hemostasis, the clinical features of the deficiency state, and the diagnosis and treatment of our patients. So PAI-1 is a member of the serine protease inhibitor superfamily. The gene is located on chromosome 7q21. It spans approximately 12 kilobases and consists of 9 exons. It's synthesized and secreted from endothelial cells, megakaryocytes, hepatocytes, and adipocytes. And it plays a role in many different systems. It's involved in hemostasis, wound healing, angiogenesis, ovulation, embryogenesis, inflammation, tumor metastasis, and vascular senescence, as has received some public attention. So essentially, plasminogen activators, urokinase, and plasminogen activator, TPA, circulate in the plasma as a reversible complex with PAI-1 in their inactive form. When the fibrin clot is formed, plasminogen and TPA or UPA bind to the clot and form plasmin, which results in lysis of the cross-linked fibrin to fibrin degradation products. PAI-1 also binds to fibrin, and when bound, can irreversibly inhibit plasminogen activators, and is thereby termed a suicide inhibitor. So the clinical features of PAI-1 deficiency, essentially, so it's autosomal recessive in inheritance. The prevalence is largely unknown, but it's a very rare disease. And the bleeding episodes most often occur in the setting of surgery or trauma. It has been linked to some spontaneous bleeding episodes, but that seems to be a lot more rare. Generally speaking, there is some kind of inciting event. Certainly, we do see a lot of abnormal uterine bleeding. We do see antenatal and postpartum bleeding with sometimes difficulty carrying to term. There is a fair amount of bruising and hematomas and epistaxis in addition. So the IHTC identified a kindred from the old order Amish community, which has now been followed for over 25 years with a rare loss of function mutation in the SERPINE1 gene encoding for PAI-1. So one of the pitfalls of this diagnosis is it's difficult to make based on laboratory testing. PAI-1 has diurnal variation. The higher values are in the morning. There's an nadir in the afternoon. So the best, it's usually to test first thing in the morning in a fasting state if you are going to test. The typical coagulation studies like PT and APTT are completely normal. Euglobulin clot lysis time is shortened due to increased fibrinolytic activity. That could provide a clue. There is specific PAI-1 testing. PAI-1 activity assays sometimes include 0 within the normal range, and it doesn't allow us to discriminate between a normal and an affected individual. there is a lack of standardization in interpretation of testing. The antigen testing should be performed, but it is not helpful in dysproteinemic patients. There is a clear diagnostic gap that exists with the use of presently available PAI-1 assays. This results in either over or underdiagnosis for patients. One of the greatest needs in this very rare disease is to develop an approved PAI-1 activity assay that is able to discriminate between affected and unaffected individuals. And in the meantime, genotyping has proven to be very useful, particularly for us in our patient cohort. And it is available for the SERPINE gene through the University of Michigan. A lot of our patients experience abnormal uterine bleeding, as we had discussed, even for the type 2M patients. And within the plain community, antifibrinolytics really have proven to be very effective and have been well accepted by patients. And another treatment that is often used by these women is progesterone cream, which they use alongside the antifibrinolytics. To be clear, it is not a standard therapy at IHTC for other patients with bleeding disorders or heavy menstrual bleeding, but it is preferred by the old order Amish patients as felt as part of the culture. They do seek out natural remedies and do not wish to use other medications. And most women within this community decline oral contraceptive therapies and IUDs. And so iron supplementation are routinely recommended, and there are several supplements that are popular amongst these patients. So we do have a treatment protocol for pregnancy for PAI-1. As we had talked about a little bit earlier, there's a lot of antenatal bleeding, vaginal bleeding during pregnancy that occurs in this patient population. So in the first and second trimester, we do use tranexamic acid for intermittent bleeding, which appears to be effective. And then beginning the 26th week onward, we do recommend prophylactic continuous use of antifibrinolytic therapy until delivery and for at least 2 weeks postpartum or until healing occurs. The teratogenicity is really unknown. Tranexamic acid is considered to be a category B medication. We do try to avoid it within the first trimester if possible, unless we do have ongoing bleeding. Overall, tranexamic acid appears to be better tolerated than epsilon aminocaproic acid due to gastrointestinal side effects in these patients. I do have a patient case of a 36-year-old homozygote. With the first pregnancy, as per our protocol, tranexamic acid was recommended at about 26 weeks gestation, and our patient developed vaginal bleeding at 30 weeks, at which point she started taking the tranexamic acid sporadically. And unfortunately, the vaginal bleeding continued and worsened. And so she then developed profuse hemorrhage requiring transfusion and admission, and then underwent emergency C-section at 35 weeks gestation. And she also received additional supportive therapy at that point because her course was complicated by DIC. With the second pregnancy, she did start on tranexamic acid at the dose of 1,300 milligrams 3 times a day, beginning at 25 weeks of gestation, which was continued throughout pregnancy and for several weeks postpartum. And she delivered a healthy baby without any complications. This is a very interesting concept, which has sparked a lot of discussion and a lot of thought at our center over the past several years. Murine models of complete PAI-1 deficiency express hemostatic abnormalities, and they develop age-dependent cardiac fibrosis, which led to the investigation within our patients, whether these patients potentially had the same effect. And 7 out of the 10 complete PAI-1 deficiency patients were found to have cardiac fibrosis ranging from 1 to 19%. We unfortunately had a 32-year-old patient with 19% cardiac fibrosis and an ejection fraction of 32% who passed away from sudden cardiac death. So we do recommend for our patients with complete PAI-1 deficiency to undergo transthoracic echocardiogram beginning at age 15 to assess ventricular function and to perform cardiac MRI as needed to quantify the percent fibrosis and progression. So to summarize, PAI-1 deficiency, the bleeding symptoms appear to be similar to other bleeding disorders that we had discussed today. Oftentimes we do see mucosal bleeding. Spontaneous bleeds are not that common, but however, abnormal uterine bleeding and heavy menstrual bleeding and pregnancy complications are common. The current laboratory testing leaves much to be desired at present. Genotyping can be very helpful in diagnosing these patients. Treatment consists mainly of antifibrinolytic therapy, and cardiac fibrosis has recently been found, discovered to be a significant sequelae, and monitoring is highly recommended. We do treat several patients with hereditary hemorrhagic telangiectasia who are part of the plain community. So HHT is an autosomal dominant disorder and is primarily caused by variants in the ENG ACVRL1 or the SMAD4 gene. And genetic testing of these three genes identifies a pathogenic or likely pathogenic variant in 85 to 95% of patients. HHT is considered a rare bleeding disorder, and mucocutaneous telangiectasia causing recurrent epistaxis is the most prominent feature in this disorder, with the vast majority of affected patients developing varying degrees of nosebleeds by adulthood. It can be associated with significant morbidity and decreased quality of life and mortality. Unfortunately, part of the problem with HHT is that the majority of affected individuals remain undiagnosed and hence do not undergo screening and treatment for the disease-related complications. So about 90% of patients with HHT will ultimately develop spontaneous and recurrent epistaxis by the 5th decade of life. The epistaxis severity score is used to monitor the severity of the nosebleeds and the response to treatment. The common AVM sites in patients with HHT include the lungs, the liver, the stomach, and the GI tract, and more rarely, the brain. Currently at IHTC, we care for one multi-generational family in the plain community with 8 affected individuals who have been diagnosed with genetic testing revealing a variant within the ENG gene. We have about approximately 121 patients we care for with HHT in our clinic who are not part of the plain community. So as previously discussed, these are the clinical Curacao criteria, and our patients within the plain community follow a fairly typical course of HHT with spontaneous and recurrent nosebleeds. There are family members who have lung AVMs as well as brain cerebral venous malformations and multiple telangiectasia within the typical locations. So to overcome the challenges to providing care for these patients, communication is one, because many times these patients do not have telephones or email. We can't do video conferencing. It is a challenge to arrange for encounters. We are lucky enough to have outreach nursing who can go directly into the patient's home and provide care and even do hemoglobin and hematocrit testing to be able to infuse them with the appropriate factor products. We do utilize telephone appointments. So there are some patients within the plain community who do have telephones, or sometimes the nurse, one of our outreach nurses is actually able to bring the telephone to the patient. We do utilize voicemail boxes, which most of our patients do have. We have written paper letters announcing the fact that we were planning to come for a visit to discuss certain, whether it's clinical trials or clinical care. We do host outreach clinics where we travel either to the patient's home or we meet them at certain locations like the community health center. We host pizza parties from time to time when there are when there's news to be shared in terms of treatment of bleeding disorders or announcements to be made. Transportation does pose to be an issue, and it's sometimes mitigated by having prearranged drivers that are able to bring patients to their appointments, and coordinating patient appointments with other family members and other affected individuals within the community can be very helpful. Establishing that physician-patient relationship that is based on trust, that allow us to actually bring care and provide care for these patients, is built on a multi-tier process and requires a lot of forethought and cultural sensitivity, truly. It is helpful to sometimes use bleeding assessment tools to help quantify the amount of blood loss. There are shortcomings, as we had discussed, but it does allow us to actually ask specific questions and understanding the right way in which to ask those questions and who else is present in the room, to make sure that the patients with whom we are leading the encounter feels comfortable and at ease in order to share that information comfortably. One thing which we have learned in caring for these patients is the importance of being aware and having a good working knowledge of herbal and naturopathic medications and their associated potential for bleeding risks. We do encourage our patients to bring those medicines into their visits so that we can go over all of the ingredients with them in order to hopefully limit the potential bleeding that they may encounter as a result of it. Thank you so much.
Thank you. All right. Well, I want to just take a moment to thank you both again for joining us this afternoon. We appreciate your time and your expertise. I'd also like to thank everyone watching for joining us today. Please note that this recorded webinar will be available on Friday, February 25th at hemophilia.org under the Events tab with all of our archived webinars. Also available in the Events tab is our upcoming schedule for our weekly Wednesday webinar series. Thank you for joining us this afternoon and have a wonderful week.